Welcome back to another episode of Align Authenticity, and as you can see, the setup's a bit different. Today we have Nathisha.
Hello.
Who's a psychiatrist, and I'm so glad. Thank you so much for coming on to the show.
I think we've had this chat quite a few times on spin bikes and on like deadlifts, in between deadlifts, but it's good that we formalize a session to talk about mental health.
Yeah, so for some context, me and Nathisha, we go to the same gym.
Yeah.
So we were spinning on our bikes one day, and then I was like, "Oh, you're a psychiatrist.
Yeah.
Hey, would you like to come on to the podcast?"
Let's just kind of talk about mental health in between, like dying from the spin bicycle.
Yeah, whether it was in the dark or the light, right? What we do with this podcast is where we try to give a lot of information to people in a way that is easy for them to understand.
Yeah.
So can you tell us like what a psychiatrist does?
Sure. So we're essentially medical doctors. So we've gone through medical school, and then we go through the process of, in Malaysia, housemanship. And so then we decide if we want to specialize in psychiatry, we do the process of training.
Yeah.
So for myself, for example, I started in 2012, I think, and then in various capacities. So a medical officer, and then in training for my master's, which is the equivalent for specialization in psychiatry. And then now in the capacity of a psychiatrist, and then also in if you decide to subspecialize in certain areas, you can. So essentially we are doctors, but we work very collaboratively with psychologists and counselors. So it's very much like cogs in a hopefully well-oiled machine, right?
Yeah.
So we work very collaboratively, synergistically, essentially to make sure that mental health is preserved. So generally that's what we do in psychiatry.
Yeah, I know you guys are the experts definitely when it comes to the meds also. And about when we're talking a little bit about case management, where you said like, okay, you work with this clinical psychologist and the therapist, so that collectively, right? So, but as I understand, because I would think that when you go to a psychiatrist, one is about the medication, and maybe they will ask certain questions like, okay, what are some of the changes that you've noticed when it comes to taking the medication, and then you look into the, for example, were there certain events that have happened? Yeah. But do you guys also go into it deeper, like let's say from that therapy portion?
Yeah, very much so.
Okay.
So I suppose if you just kind of go through what happens when you see a psychiatrist. So you'd get a referral letter and you'd come in, and you usually come in with a symptom. So it could be something like feeling low, feeling sad, but that's a very human experience, human emotion, right? Yeah. So now our job is to kind of look firstly to see if are you fulfilling a criteria for a diagnostic disorder. So we will go through the intake assessment and we kind of get some questions going, because we want to make sure we're not pathologizing human experiences. Like sadness is a very, very normal experience, right? But it becomes problematic, it becomes a disorder when dysfunction happens, when there's some deficit there, right?
Yeah.
So we start off by kind of going through the symptoms, see if it fulfills any criteria. But then it doesn't just stop there. So for us, what we also want to look at is the psychological aspects of why are you having depression for right now. Yeah. So biologically, there's definitely reasons for that. There's definitely a biological basis for depression, for example, right? But we also know there are psychological underpinnings for it. So we kind of we'll start off with looking at what predisposed you to develop depression. So maybe childhood events, adverse childhood events, your attachment, things that have happened in childhood, any biological factors, like if you've got risk factors in terms of family history, that's definitely going to affect you, not just in terms of the genetic loading, but also the way you've been parented by a parent who's got mental health issues. It might be different, right? So you're going to look at predisposing factors, and then we're going to look at right before what happened. So what happened right before this to precipitate. So a lot of times people come in with like a life event, and that could be grief, that could be a role transition from something that they've not been able to something they've been comfortable doing to something new. So we kind of look at that, and what about that was a problem for you? So why are you having difficulties transitioning to a new aspect of life, right? And then we also look at what will potentially perpetuate this. So that could be the way we think, the cognitive errors, so the way that we sometimes misconstrue certain things. That could be in terms of your coping. So if you've had copings that are not very adaptive, that are slightly more maladaptive, then you're going to have to look at that, because that will perpetuate your depressive disorder. For us, we also tend to look at what are protective factors involved, because we want to use that to enhance our treatment and strengthen the treatment process. So there's definitely a lot of psychological factors, and we do all of that in terms of the assessments, and that's very crucial. So I think the idea is that psychiatrists just give you medication and bye-bye, you're done. But a lot of these knowledge helps us tailor our management plan, and that is very psychologically driven as well.
Yeah, but I love that, because I think that you're right. I think that there's also a lot of the understanding out there, and even for me, admittedly, sometimes I know that psychiatrists, like in the experience I've seen, that when you go to them and you talk about it, they do ask a few of these questions, like what has happened recently that has affected your functioning, right? And what you were mentioning about the human experience, because are you just sad today, or are you sad throughout the month? Also, I think all of that's great. But from what I have also seen is where for a lot of people, in Malaysia or so, is that when they go to the psychiatrist, very often these questions may not really be asked. So maybe that has also led to that idea, perception, right? That you just focus on the meds.
So again, there's individual experiences in the context of seeing a psychiatrist, right? So it depends on I suppose the approach your psychiatrist takes with you. But generally, these things should be covered in your assessment. You kind of have to talk about it. And whether the interventions are done by the psychiatrist versus, say, we refer out to a psychologist, that's definitely something that is possibly the case. But generally, you will cover all of these things when you see a psychiatrist. You should.
Okay. So, as a psychiatrist, right? Let's say someone comes to you and they have had this issue with, the way that they are functioning. So, functioning basically means like, okay, maybe your appetite is gone, or you just don't have the motivation to do things or so, right? Or all of those things. So, let's say when they come to you, and then, do you take like a few sessions first to see like, all right, is this something that needs meds or does not need meds?
It's a good question. I suppose it also goes back to severity of symptoms. So a lot of times in our initial assessment, we spend enough time with the client, we get a diagnosis. Like if it's depression, it's pretty easy to fulfill criteria. You go through the criteria, we can get a diagnosis straight away.
Right.
Collaborative care, especially with the way now everyone kind of everyone advocates for themselves. So I think it's important to kind of have a shared decision-making process when you're discussing medication. So depending on the severity, that can be a conversation that you have with your client. So if you've got mild to moderate symptoms, definitely medication is an option. So it's important to kind of talk to your client about it. So in the context of how fast it takes to come up with a diagnosis, it really depends on, I guess, symptoms, the severity and the level of dysfunction it's caused. So sometimes, cases like depression, you also have a whole spectrum of mood symptoms, right? So you can come in with like feeling bad after a breakup, for example. And that's a normal human experience, but it can also then become a bit more overt, and then you kind of get an adjustment disorder, which is another diagnosis on its own, right? But if we don't intervene at that point, then we are heading towards the depressive disorder, major depressive disorder. So kind of where you're meeting your client is also important, and the decision on whether you want to take medications right up also kind of depends on both your client as well as the severity of symptoms that you're seeing. So things like depression, we can kind of pick up pretty fast. But there are some disorders like bipolar mood disorder, for example. So someone comes in and they're depressed. But so usually you think, oh, this is unipolar depression. So it's just straightforward depression. But usually with time or with further sessions or with family giving you more history, collateral history, you kind of pick up things like, oh, maybe this is actually bipolar depression. So you've got hypomania features or whether it's manic features. But this also takes time to kind of get. So usually a client comes in alone. If he comes in with someone else, great, you can kind of get your collateral history from there. But sometimes you don't have the opportunity, so you might want to schedule your subsequent session to involve family. So I think it's very important because, especially in psychiatry or in mental health issues, it's never just about the individual. It definitely has an impact on.
For sure, because mental
yeah.
health in itself is not just about you.
Yeah.
You know, it's also about the effect that you have on other
Precisely.
people. How
Yeah.
are you relating to other people? So I love that you mentioned that about the bipolar and the depression, right? Because at least when it comes to depression, and in a very human experience, is where people don't go to the psychiatrist or the therapist or the psychologist when you're feeling great, right?
Yeah, exactly. Everyone comes to us when there's a problem. No one,
There's a problem.
But you
feel like
can
that.
actually, you know, a lot of people can actually go see a mental health practitioner when you're feeling good, because you kind of want to make sure you are able to have strategies in the event that life happens and you don't feel good.
And exactly because of that when they are going there only when they are feeling low, right, there are quite a lot. I don't know about now, but I know that in the past also that the depression can be, as in the bipolar depression, can be misdiagnosed as
very much so.
depression.
Yeah.
So what happens to some of them is maybe they are going for years on the wrong meds.
Yes,
right.
And this is sometimes, I mean, we're looking at a person cross-sectionally, but it's very important to make sure that we're getting a longitudinal history as well. And that sometimes comes with time. So we might, you know, kind of get some depressive symptoms on the first assessment. But that's why it's important to also know that when someone's not responding, you need to go back and look at a lot of things. You need to look at, are we missing a diagnosis here? And it's because bipolar depression and unipolar depression, there's very often overlaps, and a lot of people get misdiagnosed. So you're not going to respond as well as you should with the treatment. So then we kind of need to revise and look back. So always, very importantly, we need to kind of make sure we're getting like the whole picture, the longitudinal history, rather than just looking at the patient that's in front of you with the current symptoms.
But are there also differences? I mean, we're not going to get into it so heavily for today's episode, but is there also a difference in terms of the medication that's for depression versus bipolar depression?
Yes, very much so, because what we do in someone who's got depression is you would start an antidepressant. Great. If it's a unipolar depression, your symptoms should, with the interventions that you're going to provide, should kind of peak and you'd hit euthymia, which is where like regular mood is, right?
Okay.
But what happens in bipolar depression is if I give you an antidepressant, you're going to peak and you're going to hit normal levels, but then you're going to eventually overshoot and you're going to hit hypomania. So choice of medication is very important. And that happens a lot of times to certain clients, which is they come in with symptoms because they've never had hypomania symptoms prior to this. And then when you start an antidepressant, they start switching over to hypomania or worst case scenario, manic.
So what does hypomania and manic look like for people who are not familiar yet?
So mania you kind of pick up pretty fast. So what happens is you get like very expansive energies, you get very elated states of mood, can sometimes border into irritability, and this comes with like a whole host of other symptoms. So you start to see your speech picking up, you'll start
so you speak like Speedy Gonzalez?
Kind of. Okay. I mean, and that was a concern of mine because I generally speak fast. I'm like, So generally, your speech is, so we go back to your baseline, right? And we kind of compare that. So your speech goes up, you have a lot of plans, so you have a lot of goal-directed activities. So suddenly you kind of have this idea popping into your head and then that idea. And these are kind of ideas that are never coming to fruition. Like you're never going to complete it. It's just pop, I have a lot of ideas in my head and I kind of want to do a lot of things. Right? And that kind of manifests into like spending excessively. So you might see someone coming in with debt, a lot of debt, because of all this excessive spending.
So it's like impulsive.
Kind of. And so that's why one of the things that we do is making sure we're not missing out diagnoses. Because like, for example, something like spending excessively, is this bipolar disorder, is this ADHD, is this borderline personality disorder, all these overlap as well. So when we do our assessment, we kind of tease through that. But coming back to the symptoms of mania, so you kind of have like an inflated self-esteem, you kind of feel better about yourself in a lot of cases. So in mania, it kind of overshoots to the point of causing quite severe dysfunction, and it lasts a bit longer. So usually about a week of symptoms or so, and the dysfunction is quite apparent. The thing that we often miss, and a lot of people also often miss, is the hypomania episode, because it's very to a point, very productive. Like people are just working for long hours without needing sleep. So sleep's another symptom that we kind of miss. So a lot of people have decreased need for sleep. It's not insomnia where you can't sleep and then you wake up the next day feeling really tired. This is a decreased need for sleep. So I only sleep 2-3 hours, but I'm fine. I've got all the energy in the world to kind of get all the tasks done that I need.
But then they crash after that.
Yes, correct. So those are symptoms. Mania, pretty obvious a lot of times, but hypomania is where we kind of have to really tease through symptoms, and you see things like just feeling kind of extra energetic for a couple of 4-5 days or so. You'd say things like, I just feel very good about myself. I have a lot of ideas, a lot of plans. I kind of like swipe my credit card quite a bit without thinking about consequences during that period of time. So those are the things that we really need to tease out, and that's criteria that we need to go through and screen through. But yeah, so those are the differences usually.
Right.
So to come back to your earlier question of medication, yeah, definitely differs. So whether we are going to start someone on a mood stabilizer or in the context of bipolar illness, we use antipsychotics as well for the treatment of that. So medication definitely differs as well.
Yeah. Aside from the bipolar condition, but what would you say are maybe the more common ones that you're seeing right now, at least, with your clients, like in Malaysia? What are the common psychiatric conditions coming to the
surface?
surface?
It's actually interesting because we see definitely the rise of diagnosed depressive disorders. Anxiety disorders is a very close comorbid as well that we see a lot, and they present quite overtly in our clinic. So we tend to diagnose clients either in the psychotic spectrum or the neurotic spectrum. So we see a lot of the neurotic disorders like depression, in terms of anxiety. I've been seeing a lot of diagnoses for adult ADHD coming up, and I think that's very good because that's an area of population that sometimes goes kind of missed. We don't really pick up, or people don't really notice symptoms, and are supposed to advocate enough to kind of get a diagnosis. So adult ADHD is another one. We've always had the psychotic spectrums of schizophrenia, bipolar illnesses. So those are common as well. And we're seeing this in a huge population. So I think in psychiatry, we also have niche areas that we kind of focus on. So we see it in young children, adolescents, teenagers. Women's health is another aspect of challenges that you are going to face, and then you're going to have these manifestations more overtly. Men's health is another area that we're really looking at, and that's another area which has been coming to, I guess, to seek treatment. Which is great. Because
it's great.
I think men's mental health is an area which has gone under-recognized for so long, and people are kind of worried to talk about it. There's the concern of stigmatization. So it's great that this is also coming to be part of the conversation.
Right. But what do you think has caused that shift, you think? Like that now there is that changing of the trend, of course, like, I mean, if you were just to guess off the bat, what do you think are some of those things?
I think it's awareness, very much so. So a lot of people are like, 30 years ago, no one had depression, no one had anxiety. We just kind of lived life. But that's not really the case. You probably go back and ask your grandparents, you probably had symptoms that were just masked really, really well because you kind of just had to do it. So I think awareness is great because we're seeing this in terms of the cases, the caseload that we're seeing right now. And so I suppose that's why a lot of people have trouble getting an appointment within like a short period of time, for example. But we're seeing this because people are more aware. This is not normal for me to be feeling this way. It's not normal for me to be unable to focus at work or unable to focus in my life. It's not normal for me to be having this severe bout of sadness. So then when you know that this is not something that is an isolated event to yourself, and this is something that a lot of people go through, you're going to be more keen to seek treatment. Right? So I would say one of the cornerstones in kind of why it's becoming more prevalent is also because we are more aware about what's been going on, and we seek treatment.
Okay, so I guess that's also because of social media, or maybe in general, I think that people are also slightly more open to talking about it, especially this generation now, right? It's like, oh yeah, you know, you go for therapy.
I mean, comparing notes, who do you see? Who's the good one? Yeah. So but I think it's also because a lot of people have put in work to advocate for this, and I think that's great because it's tireless work, and people have put in effort and time to kind of, I suppose, normalize the conversation about mental health, which is great, right? So I think we have to thank all those people. I mean, even this is great because we're talking about it, right? And we're getting people to understand that this is something that you can get help with. You don't have to struggle and, you know, kind of struggle through life, right? You want to kind of thrive instead of just having to kind of mingle your way through life.
For sure, it's excellent, right? Because the more awareness you have, then the better able you are to find the support that suits you. And I mean, you know, in our line of work is where it's also very specific to that individual. Like what works for one individual may not work for another one, and that is even before you think about like, hey, would you like to take the meds route or not? The route,
very much
but
so.
you have the choice, right? So I think the other question that I've also I like to ask is that. So we've talked a bit about bipolar, and I just want to talk about when it comes to schizophrenia, just off, right? Because the general stigma about it is that, oh, you know, like what it's like. But what have you seen, like maybe expectations versus reality, like what you've learned versus practically, you know?
I think
like how would you describe it as a condition too?
Yeah, so in schizophrenia, you have psychotic symptoms, which usually come in the form of hallucinations. So commonly you'd get auditory hallucinations, and hear voices, or people would describe, or visual hallucinations, or even olfactory, tactile. So there's the hallucination component, and then you get delusions. So you get these beliefs which are not true, and they become very fixed. So they become very fixed to the point that you start to maybe react to it, and then it causes dysfunction in terms of certain areas, in terms of self-care, hygiene, self-preservation. So that's on the kind of extreme spectrum of symptoms.
So when we're talking about delusion, are we talking about like conspiracy theory kind of vibes? Or?
Yeah, so that's the common one, kind of people, everyone on
so it's like I
social
saw
media.
aliens.
Yeah,
You know,
but it can be anything. It can, and there's different themes of symptoms that you might see. So persecution would be one of those. So you kind
like
of
people
feel
out to get
people
you.
out to get you,
right?
And so I think it's very interesting because the experience is so vivid to someone who's going through that episode at that point of time, and it's very hard on them because they truly believe this, and I think that's why we kind of need to humanize the experience also, because it's very difficult to kind of believe that someone's out to get you all the time. Right?
But I think it's also, I mean, correct me if I'm wrong, there's probably that part that it's also very challenging, right? Because someone could tell you, no, I'm not out to get you, no, I'm not out to get you, but for them to really be rooted into that instead of being carried away by those.
Correct.
Right?
Yeah. And so early awareness is great because once we pick up and we treat well, and we make sure someone goes back to a period of not having symptoms or remission, then great. Then you're able to live a life that is very functional. And I think that's the common misconception, that if you have a diagnosis like schizophrenia, your life's over, you can't really function. But that's not the case. A lot of clients that I've worked with have exceptionally well-lived lives after that, because you treat well, and that's something that we kind of want to make sure is the quality of life that is preserved subsequently.
So, but for schizophrenia in particular, right, is it where, like, how does it look like when it's well managed? Like, one is okay that they are able to function and do things or so, but like, are there still some of those things that happen, like the voices in their heads?
So if you've got a treatment plan that is working well for you, no, you will have no symptoms. You won't have hallucinations. Your delusions would not be present, or at least even if it is, that you won't be acting on it. So
it's not so intense.
Correct. It's not so intense, but they do need medication long term to kind of keep at it and keep your symptoms at bay, right? So that's often the challenge. Once you get treated, I need to take medications for a very long time. And that's where we often have challenges, which is getting someone to come and take medications every whether it's oral medication, which is every day, or we do have injectables, which is like once a month. So, or even longer, three times in a month. So it's about compliance after that. So we don't just stop at once we're diagnosed and you're done. We want to make sure that you're going to continue your treatment plan. And this is not just treatment in the sense of medication. And this is where we often have a lot of new things cropping up. So once someone goes through schizophrenia, has an episode of schizophrenia or a psychotic episode, when they're well, the risk of developing depressive symptoms become very prominent. So because you've got a lot, one, it's a diagnosis which is pretty stigmatized to a certain degree. So you've got a tendency of realizing, okay, I have a lot of things that I potentially may lose in my life, right? And how it's affected you during the period of a psychotic episode. So whether there was issues with your family, did you react in a certain way to family, for example. And so then you're going to start realizing, oh, there's a lot of areas where I've had some dysfunction. And so now that's going to kind of creep in. And then they start to have feelings of like, what's the point anymore? Am I going to be well ever again?
So you feel hopeless.
Right, you feel hopeless. So that's also something that we do want to intervene fast. So we're not just looking at kind of getting through the episode and okay, that's it. There's so many things. Anxiety is another one that happens after that. Am I going to get another relapse? How am I going to live my life? Am I going to have people who understand me around to support me through an episode or through my treatment plan? Right? So there's a lot of issues that can also creep up. So we're not just looking at the person one-off. We're definitely going to be able to follow them and want to follow them.
It's also very interesting how it works because like let's say in some cases when they have the light symptom, like symptoms of anxiety or ADHD, and then it can also progress to more severe ones, right? And
so ADHD is a good example of that. So a lot of my clients that come in with depressive disorders. So yes, we've got those coming in wanting okay, tell me if I have ADHD or not. But a lot of them come in with anxiety symptoms or depressive symptoms because at some point the compensatory mechanisms that they've kind of worked with
it's not working anymore.
It's not working anymore. And we usually see this during transitions in life. So say someone who's gotten pregnant or who's got a newborn, suddenly the things that I used to be able to do to cope are not going to be able to cope. And what happens there, I develop like anxiety or I get worried. Am I going to be able to cope? Or I develop depression, right? So am I going to be able to take care of my child well enough? So we see a lot of, and they're very intertwined, I suppose, a lot of times. So
it's not just intertwined, it's also like stacking up
Correct.
on top of each other,
Very
right?
much so.
So even more so, they're not going to feel particularly like hopeful about the situation.
And so that's where our role comes in, and we come in early, which is when I diagnose someone with, say it's schizophrenia or say it's ADHD, I want to kind of equip them with enough skills to prevent all the subsequent comorbids that might occur. So we're not just focusing on that problem, we're kind of also making sure you're still able to go on with life, you're still able to cope with the rest of the challenges that you might have to face. Right? But so we provide them skills. And that's where psychology or the psychological aspects come in, right? Are we going to work on your coping skills? Are we going to work on problem-solving skills? Are we going to work on interpersonal communication? How do you work with the people that you love the most, right? How do you talk to them? So how do you ask for help? That's another big one. How do you ask for help?
I'm actually a lot for, I mean, on a side note, I think that the idea of case management is great because
very much so.
Yeah, because like even in the UK, at least when it comes to the doctors and the pharmacists, they have that. And I think that, so how it works there is where, okay, the doctor tells you that you have something, but then you also maybe have to get your medication from the pharmacist. So there's like a filter there already in that. You have to make sure that, okay, it's all aligned, and then there's a higher chance that you have that. So, I mean, in our context, in the context of mental health also, it's like what you said, because the psychiatrists, you guys are the experts when it comes to meds, but maybe in some cases is where you're stretched, you know, so then you can leverage also on the clinical psychologists and the therapists.
And we do that. At least in settings that I've practiced in. So we do have rounds or discussions about a client, for example, and we kind of get input from whether it's a psychologist, whether it's the pharmacist if there's an issue with medication, whether it's the family if it is necessary, right? But we do want to look at the client exactly like you said, in terms of holistic care approach, right? So and then we use case management.
It takes a whole village.
It definitely does. It definitely does.
Right,
Which is good because we also know that once the village is established, you can kind of reach out and get the support you need. Sometimes the challenge is getting that village, kind of establishing and making sure you have that village when you need it.
Yeah, and I guess in the, how it is at least in Malaysia, right? And of course, we're not villainizing medicine, we're not villainizing like the system or so, right? But if you were a client or you are a patient and you feel that maybe the meds are not really sitting so well with you, like, or so how would you go about having that conversation with your psychiatrist? What do you think are some of the questions that they should ask?
It is so important to advocate for yourself.
Okay.
So I think even as clinicians, we're kind of moving away from a paternalistic, like I tell you to take your medicines, you take your medicines, don't ask any questions, right? And we should be moving away from that because if someone's not going to take their medications and you're afraid to come and talk to you about the medications or the side effects, then we're just going to lose you in the process of care, right? You're just going to not come, you're going to default to appointments, and then we've just lost not just you, but also a lot of functionality that you've been able to provide for the ecosystem that you're in, right? Your family, your work, right? So we want to make sure that it's not the case. So I think from our end as clinicians, we want to make sure that we're trying to be very receptive to your feedback. And
there's this new trend also on Instagram, but that's among the medical professionals, the Gen Z slangs.
Oh yes. Okay, so I've kind of had to kind of pick up a few things there myself. But yeah, I mean it's great. You need to relate to your clients, right? So if I'm on like slightly higher pedestal and I'm not trying to understand where you're coming from, you're not going to open up to me. And I think that's where we build a therapeutic alliance, right? So and that's a very key part of treatment or therapy, which is you need to be able to trust me, right?
It's like I need low-key bestie vibes.
Yes, exactly. All of that, and which is great because you're going to relate and someone's going to feel more comfortable. So if your client, you need to kind of pick up a few Gen Z lingo to kind of relate to them, great, by all means. But so I think on the end of a client, please speak up. Like, please tell me that you've got a problem with your medications, and then we'll see what we can do about it, right? There are a lot of options of treatment, so it's important for us to understand. And a common reason people have problems with medication is side effects. And if you've got a side effect that is intolerable to you, I definitely want to know about it because that's going to be the reason you don't take your medications. So I think on both ends, kind of advocating for yourself is very important, and for clinicians, it's very important to be receptive to what is being said to you.
But I think that also a very real thing that some of the clients that you say, especially when they're much more used to maybe certain medical professions are, hey, take it lah, don't ask so many questions, right? Just do it. So they may not even know when they are experiencing certain side effects, right? So what would you say is some of those points, or maybe like now is the point that you should highlight to your
and so that's actually, so if I go back to the initial assessments, I'm going to tell you what to look out for.
Okay.
And so then you have awareness. So when we go through the initial assessment, we've picked up a diagnosis, we've gotten a treatment plan in place. And this treatment plan is not just for today or for the next week or 2 weeks. It's a long-term plan. So we're going to tackle right now issues, and then we're going to tackle support system that you need to be enhanced to help you get through, and what are things that you need to anticipate long-term. And that includes medication side effects. So if you have awareness, if not, you're just going to have, why am I feeling this? Or there's that placebo effect of like, oh my God, am I feeling like a side effect? Right? So if I tell you what you potentially might experience, you're going to be more aware. And then you're going to be able to kind of tell me if that's present and the level of dysfunction that is had. If a lot of side effects, and also one of the things is a lot of side effects tend to self-limit. So if like the first couple of weeks, like antidepressants, for example, if you take it, it's still tolerable, you have a few symptoms, but I know that it's going to self-limit within a couple of weeks or so in some cases, then okay, I can make a decision whether I want to continue through it because it's not too severe, or I need to change.
Well, what does it mean by self-limit?
Oh, so
then
it goes
in this
away
context?
within a
Right.
while. Your body kind of adapts to the medication,
right, okay.
and then I'm good with it.
Yeah,
right.
yeah.
But that knowledge needs to be delivered to you, and so knowing that will then give me the ability to decide, okay, what do I want to do with this, right? And asking for a medication change is fine, but it's of course a discussion that you need to have with your doctor. So for example, you've tried a lot of medications and maybe you've got other medical reasons for why you can't be on this medication.
Yeah.
So then we need to tailor a plan that's specific to you. So I suppose individualizing a care plan is great. There's no one fit medication. There's
Yeah,
not like,
for
okay,
sure.
you take this antidepressant
Yeah.
and that's it, right? Everyone gets like, you get a car, like, right? So it's not like you get an antidepressant.
Yeah.
It's a tailored approach, and
Yeah.
it needs to be that way.
Let's say you're put on new meds, okay, or one of the patients in that sense. Then how long would you say general, because even though it's different for everyone, but how long are we thinking of in terms of like to see whether, hey, is the medication working, are you adjusting or it's not?
Yeah.
You know?
So dependent on a few factors. So we're not just looking at medication being the solution for everything.
Yeah.
Right? So we're going to combine it with your psychological interventions as
Yeah,
well.
for sure.
So for example, antidepressants, give or take about a couple of weeks, and then you see some symptoms. So I'm also going to make sure that you know what to look out for in terms of improvement.
Yeah.
So whether it's your energy levels peaking up a little bit, whether it's your sleep regulating a little bit, whether it's the ability to focus on things a little bit more. So those are things that you're going to kind of have to look for. So we usually give a time period of within about a month, 2 weeks to a month to see some improvement.
Okay.
Then we're also going to look at what areas are still deficient and how do we cope with that.
Yeah.
So again, time frame really depends on your client and also the severity of symptoms. So if someone comes in with suicidal ideation, for example, suicidal thoughts, I'm going to want to make sure that is taken care of.
Ooh, accelerated.
Yeah,
Yo,
very fast, right? So because I do not want someone going out with that still present, or at least I don't have a support system to kind of manage that. So whether medications take some time, but I know I've got a safety plan in progress. I've got someone who's going to be able to monitor my client as well. So it works hand in hand, right? So the expectation of how long you will need to see, it depends, and that's a conversation you need to have with your therapist. And so I guess also it depends on what is the issue at hand. So I had clients come in with ADHD and they are at the brink of losing their job. So I need to see results, and I need to see results fast, because if I don't intervene, whether it's through treatment or whether it's by them explaining to their bosses that they've got these diagnoses and what modifications or adaptations we can kind of set in place, then they're going to lose their job. So it's important for you to also feedback to us what are the areas that you really are struggling with.
That's really why that therapeutic alliance is very important.
Very much so.
And I always say to clients or even people in general, I'm like, look, if it's not working for you, like you just don't feel you can voice it to your therapist or your psychiatrist or whatnot, change, you know.
But I mean,
or just get second opinion.
That's actually true, because again, and it could be so many factors, or it could be nothing about each individual it's on its own. It's just the approach sometimes differs. Therapist to therapist, psychiatrist to psychiatrist. It's just maybe the receptiveness to how you feel about that, or the challenges that you might have in terms of how you want to build an alliance with your client. So if you don't feel comfortable, by all means, you're allowed to ask for second opinion. You're allowed to ask for a change if you need to, within the context of where you're working, you're seeking treatment.
I love to ask more questions, but in the future episode about the medication. But in general, for now, I have heard of which I find a bit odd, but since you're here, I'll ask you, right? It's like I've heard of one or two people out there where they went to a certain psychiatrist also, and they got meds, but it's like it's always being changed.
Okay.
Like after 1 month or 2 months, it's changed. So Is that something that's common, or is it not supposed to be happening?
I'm not too sure about the individual, but on an overall spectrum, so there's reasons why we change medications, and it's usually response or side effects.
Okay.
And those are the most common things. So if you're changing very fast, could it be with side effect that the client is finding intolerable? So we have to change. And the side effects may not be something that is experienced. It might be something that we've picked up on a lab test, on blood tests, right? So if you've got like a liver derangement and that we can kind of tie it back to your medication, I'm going to want to make sure I potentially switch treatment. So it could be that, it could be non-response, but that one we usually give a bit of time to see response as well. So one thing that we can do is objectify the assessments to some degree, because psychiatry tends to be somewhat subjective in certain aspects. So we can use objective tools to kind of assess progress as well. So coming back to the question of why it's shifted, it could be many reasons.
But those should be the two main ones.
Yeah, but it's also very important for you to know why you're changing medication. So I guess it goes back to asking and kind of understanding what's going on with you and why is this happening. So I think that's really important, that we have taken ownership of your health, your diagnosis, and we advocate. And as clinicians, we listen to you when you're advocating for yourself.
Actually, nothing wrong, with asking questions,
By
because
all
you
means.
already pay already, right?
Yeah.
So you should be able to ask the questions.
And more than just the payment, it's also because this is your life and
Yes.
your health.
Yeah.
Like, we know the impact of mental health on an individual. We know how it can seep in very subtly in various aspects of your life. And so we don't want you to be struggling, or we don't want your loved ones to be struggling as well. So it's very important for us to kind of get you the right treatment and the right fit of management. So hopefully, you improve.
Yeah. I mean, well, at least in therapy, at least is where, okay, let's say someone is in that really tough spot, then we would say that at least how we actually look at if there's improvement or so is that we get you out of that danger zone in a shorter amount of time. Right? Would you say that that's also similar for psychiatry?
Yeah, so we generally go by a risk assessment approach also. That also kind of helps us tailor our plan for you. If you've got imminent risk, we're obviously going to tackle that the most imperative form of a part of your treatment, for example, right? So we will want to make sure that that's taken care of, and that can be done in so many ways. So in our case, the two most overt risk issues would be aggression or suicidality, right? So once we've taken that and we've dealt with that, that comes of priority. Once we've taken that and we've dealt with that, then we look at everything else that comes into play as well.
Okay, that's great. Yeah. And when you're talking about the protective factors, right, around, so there's so many different types, like, for example, like, let's say someone that's kind of going through, aside from the meds or possible therapy, or so it would be health, nutrition, right? But what would you say, or how has it been like now with in terms of like the clients that you've seen, in terms of the family support maybe, or the friend support?
So again, I think when there's awareness, there's a willingness to provide support, which is great, right? So we're going to be able to engage, and people understand what you're going through. You're going through not just macam what people will say mengada-ngada, or just like macam people
like
just
buat drama.
Macam buat drama, but this is not. This is an illness,
it's a real
right?
thing,
So or just like suck it up and kind of deal with it. It's just like, why are you feeling sad, right? And that's not the approach. So people kind of understand that right now. But of course, it is also challenging. So sometimes we start off very much with educating, and psychoeducation is a big part of the initial assessment. It's not just to your client, but also the support system that they want to bring into the picture, and that can be at varying degrees. Someone might not feel comfortable letting everyone know, so we start by who do you feel most comfortable bringing into session with you, and then we kind of talk to them about offering support in the way the client needs. A lot of times,
and that they're comfortable with.
Yes, correct. Because a lot of times we want to support in the way we want to support. So I'm going to do this for you, or I'm going to do that for you, but that's not what the client needs, right? So I'm going to tough love it up, or I'm going to kind of take care of you and not let you do anything, but that's not what the client needs. The client, you need to kind of understand what support is being asked for and how can we provide it as family members, so that it's well suited.
Yeah, but I guess with that also, right, have you seen like maybe a difference? For example, those that have had maybe a bit more of that family support versus those who have not had that family support, on
And
the
that's
effectiveness of the...
very much so in terms of the treatment, in terms of how fast you respond. That's one of the factors, and there's been lots of research about this, about one of the factors which are very modifiable, which is great because I can potentially modify this and that will show a lot of greater outcomes. So there are some factors which tend to be unmodifiable, genetic risk, those kind of things are a bit harder to modify. But support is something that is very modifiable in so many ways. So for example, one of the things we would talk about is how do we ask for help graciously, right? So, and that we do that in therapy, in terms of the types of therapy we do. We will talk about communication. So asking for help shows, and kind of getting the help that you need shows great results in terms of the treatment plan.
So. Maybe it's also an Asian thing, not only just the asking for help, but being willing to accept that help. Right? So
Being able to take the support is great, because a lot of times we kind of just want to soldier it up, and we're kind of taught inherently to, you just got to do it when you're old.
Double down, right?
Double down.
Harder it is, double down more.
And the more challenges you have, the stronger of a person you become. No, not really. I mean, if you can get help to get you through life, by all means, right? And so, but oftentimes we have clients who have limited access. So it's limited support. So then we sometimes kind of also have to take on that role of providing support for your client. And so that's what we also do in the therapy room, which is mimic the kinds of support that we want them to get, and that is a safe space for you to kind of be able to get the support you need, right? So we enhance whatever they have, and we also kind of provide that support for them.
So I would say a very important message from it in general is that it is challenging, yes, you know, to find out what works for you, which route you want to take, and then of course depending on whichever support. But it is not impossible, right? I think that's the real beauty of it, because even if we were to talk about all of this more severe, what they call severe mental health conditions, there are actually quite a bit of pluses to them too, because I've seen in the case of where those who maybe they have bipolar or even a bit of the ADHD, but they also have a bit of the superpowers in terms of their creativity. You know,
very much so. So we're not looking just at deficits. We're looking at areas that we can enhance, and what can we enhance in.
Play to your strengths.
Exactly, play to your strengths. And so I think that's also an integral key, because if not, you're just going to be focusing on all the things you can't do, as opposed to what else can you do, and how can we help you kind of harness this superpower to the best of your abilities, right? So very much so. We need to see the client as a whole, rather than just the symptoms of and the deficits that they present with.
And something that someone had shared with me, which I thought was also very profound, right, is that for us on the outside, when we're looking at people with this kind of the conditions, right, we can feel like, oh, you know, more scared or so. But it's actually scarier being them, you know, because it's like you walking around and feeling like, oh, people have all defined you a certain way, right? I think that's
and that's very true, because we talk about stigma quite a bit from the external. But what happens a lot of times, this stigma gets internalized to self-stigma. So then you kind of self-stigmatize yourself on so many levels, whether it's in the context of depression and you feel like, I can't do it, am I disappointing everyone? But knowing that the vulnerability that you have, which is an illness, and this is a true illness, right? So the analogy I always use is, if you broke your leg, I'm not going to ask you to run a race, right?
No marathon for you.
No marathons for you. Maybe, we might need to scale down on the red lines and your high rocks. But I'm not going to ask you to run a race, right? It's the same context, right? We need to give you grace. You need to have grace to allow yourself to heal. And knowing that it comes with time, it comes with support, and it comes with getting help, right? So that's very important. So everyone else may look and think, oh, it's difficult, but truly the person who's going through it,
it's worse.
It's much harder.
Is worse,
And so we need to give ourselves that grace to kind of get the help that we need.
Wow. Yeah, that's really powerful. And thanks so much for coming. But I guess as a last key takeaway, right, is there anything that you'd like to share with the ones listening in about maybe psychiatry or about mental health in general? Like
so many things.
Your message to them. Yeah.
But I would say, I think it's if you feel you're struggling with something and you need an opinion, by all means reach out. Get the help that you need. There's no shame in asking for help. There's no shame in kind of reaching out, getting the support you need. So it's always good to try. A lot of people are afraid that they won't get the outcome they want, so they don't try. Or they just struggle through. But you don't have to do that.
Yeah.
So by all means, get the help that you need. And what we're seeing is there's more accessibility for you to get help. So please do.
Yeah. I think sometimes the first step is the most challenging one to take, but once you take it, a lot of that fear can go away.
I think a lot of times people worry that it's on me, I have to do it. But you just have to kind of put your hand out, and then you've got an entire support system who will come in to help catch you, right? So you're not going to do it on your own.
Yes.
Right? It's not something that you're doing on your own. And we've got a collective team that is there to help you.
Yeah, that's awesome. Thanks so much, Nathisha, for your time, and thank you everyone for watching. Let us know if it was helpful for you, and like, comment, and subscribe. See you in the next one.